Hello, everyone. I'm Lisa Ling, and this is The Road to a Vaccine, an exploration of the COVID-19 crisis and the global community's efforts to develop a vaccine against the disease. We are now 8 months into the pandemic and well into the second season of this show. So much has changed since we first started. If you're like me, back when we first heard about the virus, I would have never imagined we'd be under mask mandates or that entire economies would be pushed into recession. We've been through a lot, and still it's hard to know exactly where we stand. As schools go back in session, my daughter started today, students, families, and teachers are dealing with remote learning. And many schools that have tried in-person classes have had to quickly close due to coronavirus outbreaks. Meanwhile, multiple vaccines are making progress in clinical trials. The CDC has told US states to prepare to distribute a potential vaccine in late October. Now, before we talk to our guest today, let's take a look at the numbers. As of today, and over 890,000 deaths globally. In the US alone, there are over 6.3 million confirmed cases and over 190,000 deaths. While numbers are falling in some areas, there are still many cases rising in Tennessee, Arkansas, Alabama, Iowa, Illinois, and North and South Dakota. And experts warn we could see a spike in the coming weeks after this past Labor Day weekend in the US, based on the spikes that occurred after Memorial Day weekend and 4th of July. India has now surpassed the US in new cases, and Spain has entered a second wave with nearly 500,000 cases reported. As clinical research and development and supply planning continues for the first potential COVID-19 vaccines at an accelerated pace, questions of safety and efficacy are being asked amongst the American public and around the world. Will these vaccines be well tested enough before they are available? Is the scientific review and approval process reliable? To help us address these questions, and in an unprecedented moment of unity, this morning, the CEOs of 9 biopharma companies, including Johnson & Johnson, AstraZeneca, BioNTech, GlaxoSmithKline, Merck, Moderna, Novavax, Pfizer, and Sanofi, have made a historic pledge to the world, outlining a united commitment to uphold the integrity of the scientific process as they work towards potential regulatory filings and approvals for the first COVID-19 vaccines. These companies have called on all who stand with science to join them in declaring that rigorous science and safety must be first priorities in vaccine development, and have launched a hashtag, We Stand With Science. It is an unprecedented joint commitment to sound scientific principles. Now, this show is dedicated to sharing scientific facts about COVID and giving you access to experts who can help us understand them. So in this episode, we're going to focus on where we are right now and how to interpret the numbers. Later in the show, we'll talk to former Bill and Melinda Gates Foundation CEO Sue Desmond Hellman about pandemic preparedness, and J&J's resident pediatrician Jackie Phillips about kids and COVID. Now, as always, if you have questions for our guests, please put them in the comment section, and we will try to get to as many as we can throughout the show. So first, let's get right into the latest developments with Vaccines 101. I couldn't think of a better guest to talk about the science than Dr. Paul Stoffel, J&J's Chief Scientific Officer. He is a visionary leader who has spent the last 30 years fighting HIV and spearheaded development of vaccines for Ebola and Zika. He's currently leading J&J's efforts to develop a COVID vaccine. Dr. Stoffels, welcome back to the show. Well, first of all, I want to ask you about this vaccine maker pledge that was released this morning. Why the compulsion to do this, and what does this say about the industry's commitment to safety?
Yeah, we made the pledge jointly because we are all committed in the pharmaceutical industry, vaccine industry, to make sure that people understand that we will do what's needed to prove efficacy and safety of vaccines. That's quite significant. You have to make, we have to do in a very short time a lot of work, but we commit to, we absolutely don't take shortcuts. We'll study the necessary numbers of patients in order to show efficacy as well as safety, and also we'll try to make sure that also durability is shown to what we do, and that's the commitment we all make, that we will not go for shortcuts. We'll do the right science in cooperation with the regulatory authorities in the US and in other parts of the world, and follow their guidance on what to do to get to a vaccine which is approved.
Now, what is the latest update on J&J's vaccine?
Well, we talked about in July that we started our phase one. That's ongoing. We have vaccinated the first 1,000 people, and that is now in the middle. And so we are making conclusions on starting our phase three. At the meantime, on Monday, in the course of next week, we'll start additional phase two studies to study different populations to learn more about what in elderly youngsters, the different dosages, etc. But then the phase three is planned to start before the end of September. Very significant preparation has happened over the last several months in order to get this study set up, and massive number of centers are collaborating across the world. And so hopefully before the end of September, we will be recruiting in a phase three study to demonstrate the efficacy and the safety in a very large number of people.
When you talk about a very large number, what are we talking about here?
We talk about north of 30,000 people because we think that's the number we need at least in order to be able to show safety and efficacy in a significant number of and that will include from young people to elderly people. So we want to demonstrate efficacy and safety in all parts of the population, and so that. And we will do the additional numbers if needed. So we will look and watch what are the challenges in different parts of the population and do additional studies to show efficacy and safety in those also.
And these trials will be happening all over the world, right? In different countries. So why is this so crucial to do, and what does it take to make it happen?
Yeah, it's crucial to do, first of all, to have diverse inclusion of population from all different parts of the world, so that you can demonstrate that in every part of the world, the vaccine has been shown safe and effective. But also we need to recruit in areas where there is very high incidence, because to show efficacy, you need to be able to show that the vaccine works. And there we need to go to areas where there is a lot of transmission. Unfortunately, there is still a lot of transmission in several parts of the world. And so at the moment, we plan to do this for the first study in the US, in certain South American countries, as well as South Africa. Our second study will start later in October, will be in Europe, South America, and also Africa and the US. So it will be broader in the world, but we'll try to demonstrate efficacy in all parts of the world, as well as looking for transmission, because that's what we need to make the studies work.
Dr. Stoffels, I have to ask you about safety. You know, as the host of this show, I am seeing and hearing quite a lot of concern around COVID vaccines for various reasons, including the perceived fast tracking for emergency use authorization. So what would you say to those who are not only hesitant to take the vaccine, but there are a lot of people who are just flat refusing to take a vaccine if it gets approved and becomes available?
Yeah, I think it's part of our work to educate and to learn people and to provide the right information that people understand what such a vaccine is, how it works, but then also give more information about the safety and the efficacy. But also vaccines typically have certain side effects, like typically you have reactogenicity on the place where you inject. You might have some fever for a day or something like that. So there is some side effect which could appear, but the long-term benefit outweigh. Hopefully we can show that the long-term benefit outweighs significant the whatever small side effects people will see, because hopefully we can protect people for long-term for COVID and resume normal life. But also, especially in the elderly and the high-risk population, we can prevent hospitalization and death. And so the whole objective is to prevent people from dying from the disease by vaccinating a larger part of the population to create that immunity. So more information to people why this is needed. I think people forget, and we are, I think, living in lucky times that a lot of this over the last 100 years, many diseases were taken out by vaccines. If you go back to polio, to tetanus, to measles, diphtheria, rubella, mumps, you name it, all were taken out by vaccines, and they are now not. In certain societies, yes, still some challenges, but the majority of the world is not confronted with these diseases anymore. And that's thanks to vaccines. And they have shown, most of us, if not all of us, have had many of these vaccines that are protected today for those diseases. So we have to learn to what this new vaccine will bring, and then what it will add to society, protect maybe not just yourself, but also your grandparents your parents and your grandparents from dying. So I think education is very, very important, and making people comfortable to do the right work to show efficacy and safety is going to be our task.
I think many people are worried that even if you do get through highly rigorous clinical trials and are approved, many seem to be worried about the possible long-term effects of a vaccine because that will not have been able to be studied. Can you speak to that?
Yeah, yes, it will not have been able to be studied, but it are infectious diseases, and we understand how the body works on infectious diseases by eliminating the virus. And typically, with our vaccine, we have done already a lot of work. I mean, the same vector we use to carry the piece of the virus into the body, and we have vaccinated 90,000 people in Ebola, in Zika, in RSV, in HIV, and we have demonstrated over the last 5-10 years a lot of safety data already. So from those, we know already the long-term impact and the challenge, or not, and the safety. So we can, with the regulators and the scientific community, you can deduct certain information from that, then complement it with what we study in the next, let's say, 6 to 12 months, and that will give us very good comfort for the safety of the vaccine, as well as the extensive animal work which is happening, because that shouldn't be forgotten. We learn about toxicology, the safety also in animal models, and all of that information then brings it together to be able to inform the FDA, and the FDA will take the decision. Very important for people to know is not that the industry doesn't take the decision to bring a vaccine. It is the combination of CDC, the Centers for Disease Control, and the FDA who will, in the end, take the decision which vaccine will be brought to patients. And that's where it's an independent review at the FDA and CDC who will guide that emergency use and eventually the use of the vaccine of the
as you can imagine, there are lots of questions coming in about this. Mohammed from LinkedIn asks, how are you coordinating efforts with other research groups and companies?
Well, there is a very intense collaboration with what's called active collaboration between NIH industry, where we look at how can we leverage the science, the information we learn, the data we generate, and we share that. There is a significant data sharing effort across all industry and across also the academic centers, to provide the information what we learn to everybody, so that we can. So there is a lot of collaboration, and that is instilled by the joint effort of industry and governments and institutions to get to a solution for the disease.
Can you explain what emergency use authorization means?
Yeah, in certain circumstances, the government can use a procedure which is called emergency use authorization for the cause of a pandemic, where before the full application is ready and available to the FDA to already use a emergency use. And that has been used in several very severe diseases or severe epidemics. You probably all remember HIV, and in the early days where we had to go fast, bring new medicines for HIV. At that moment, authorities can give it's a approval to use it faster than when it is already fully approved to help the world. In vaccines, this is called emergency use authorization, where CDC jointly with FDA can decide this vaccine has shown good safety and efficacy to the point that we can use it in an emergency use. we will continue, and of course we continue to generate more data for the long term, working to a full, what is called a BLA, a biological licensing application, and then get full approval. But typically for those type of approvals, you need significant, extensive, additional long-term stability. A lot of information is required for that. And that's where it takes normally 2 to 3 years at least to do that. But the government has the authority to independently decide using it earlier for emergency use.
Yeah, I think a lot of people need to understand that once a vaccine does get FDA approval, it's not like it will appear in pharmacies or be available through your doctors immediately. It will have to be done in a staggered way. So can you talk about how the vaccines will be prioritized?
Well, it will be the governments and the different healthcare authorities who will prioritize. But as we know, the risk from this disease is, first of all, the healthcare workers are very much exposed because they have to deal with the patients and potential patients. But then it's clear that the elderly, people who in nursing homes, people who have certain conditions, are at higher risk, and the prioritization, in my opinion, will happen, and that's what I learned, it will happen through all of the governments in those populations first, and then later it will go much more to the general population. So, and with that, hopefully we can reduce mortality from the disease very quickly, which will give a lot more comfort to many people, families now, that people can be protected to die from the disease.
Dr. Stoffels, there could ultimately be multiple vaccines that will be approved and distributed. So when we go to the doctor or clinic to get a COVID vaccine, how will we know which one we are getting and how the different vaccines behave in the body?
Well, it will be, again, in the emergency use period, it will be the government who will decide who will get what vaccine, depending on first, should get first a vaccine, and then they will be distributed to government channels and will be made available to people outside of the normal commercial system. It will be still, you might have to go to your pharmacy or to your primary care doctor, but it will be in a non-commercial way because we will not, it's not a normal sales of vaccines. It will be paid for by the government, and then they will do the implementation program. We will support where necessary on distribution, on making sure all the materials there to vaccinate, but it's the government who takes all the decisions on this.
So with the potential second phase of the coronavirus, how would you say treatment of COVID has evolved, and how would you say our overall state of preparedness is compared to where we were months ago? I mean, here in the United States, there have been a number of hotspot states that have reduced numbers pretty significantly because it seems people are really complying with the guidelines. But would that just be our normal until a vaccine is approved?
Well, first of all, the good news is that the hospitals and the people do clinical care have learned a lot in the first part of the pandemic on how to treat people. And so mortality, within the supportive mechanisms which are there now, mortality has gone down dramatically. So that's the good news, that where before, if people went on a respirator, there was a very high chance of dying. Today, people know, hospitals know how to manage those people. Then a small number of good supportive care drugs have been already identified and being used. That also helps. And then many first studies of antibodies is now starting. You heard about convalescent serum and the whole debate around that, but there are now rigorous studies with many antibodies ongoing, which hopefully will become available before the year end, which also can help to contribute to treating patients. And then as a next step, hopefully new vaccines will become available, whether it's before the year end or in the first quarter of next year, still debated on when we get to the efficacy and safety endpoints. But we can expect big change between now and 6 to 9 months. But at this moment, the best tools we have is prevention. And so making sure that this social distancing, wearing masks, observing number of contacts you have with your families and with and etc. is still very important. And people should follow the guidelines there because it has shown to work very well to reduce the transmission. And especially when you have elderly in your family of people who are at high risk, very important because that is going to prevent people from dying at this moment. Hopefully soon we have medication and vaccines, but at this moment, all of our individual responsibility will help to protect others from worse outcome.
I have one more question, Dr. Stoffel, from Jacob from LinkedIn, who asked, how do you ensure the safe shipping of vaccines?
That's a very good question. It's going to be a huge logistic matter, which the industry is working on together with the government to work that out. Yeah, it's our responsibility to deliver a vaccine and to deliver it to the point of where it is going to be distributed into the different whatever pharmacies, nursing homes, and different healthcare centers. But we have a very big commitment that the vaccines are arriving in good condition at the place where they're going to be used, whether that's in the US or whether that's in the rest of the world. We have a responsibility there as a company to work on that. It's different for different vaccines. The challenge of how you transport at low temperatures, minus 60, 70 or minus 25 Celsius, sorry, and then how you can bring it to the different vaccination centers, but it's our responsibility as a company to make sure that's happening safe and effective.
Dr. Stoffel, it's always a pleasure to have you on the show, and we look forward to hearing from you more as things progress. Thank you so much for logging on from Belgium. Thank you.
Thank you for
now. If you are watching, thank you. And if you are watching and have questions for our guests, please put them in the comment section, and we will try to get them answered for you. Our next guest is Sue Desmond Hellman, former CEO of the Bill and Melinda Gates Foundation, the world's largest philanthropy, where she led their efforts to promote equity around the world. She's an oncologist who worked on the front lines with HIV patients in San Francisco during the AIDS epidemic, and she was at the Gates Foundation during the Ebola epidemic. Dr. Desmond Hellman, thank you so much for joining us. Now, you've been at the center of some major public health crises, particularly AIDS and Ebola. In the 80s, you were an oncologist in San Francisco, just as AIDS was being discovered, and you went on to lead the Gates Foundation during the Ebola outbreak. What was it like dealing with a pandemic from an institutional perspective? And what can we learn from those crises as we now face COVID-19?
Well, let me tell you what the two experiences had in common. Being afraid. I think it's important for us as clinicians, as public health experts, to recognize that pandemics are frightening. In 1982, when I was an intern in San Francisco and we confronted HIV/AIDS, we did not know what was happening. And we and the patients we were trying desperately to care for had so much uncertainty and so little to do. It was interesting hearing Dr. Stoffel talk about the progression of remedies for COVID-19. We started with an antiviral, remdesivir. Now we know steroids can help patients who are in the hospital. And now I hope we will move to a vaccine. In the AIDS epidemic, we started with things for pneumocystis pneumonia and other infectious diseases. Now and then we had some little bit to do with the cancers that affected patients with HIV. But the amazing, difficult thing about HIV, a reminder, we still don't have a vaccine. 40 years after HIV was first described, we still don't have a vaccine. And it's possible to have HIV and be asymptomatic. So testing and knowing your status is extremely important. Now, happily, we have a lot of active antiretroviral therapy to help patients with HIV. So fast forward to 2014, when in West Africa there was an outbreak of Ebola. Initially, during that outbreak of Ebola, everyone thought, like it's ever been, that would stay in Africa. And those of us in North America felt completely protected. The amazing thing was when everyone recognized that, in fact, a pandemic anywhere is a pandemic everywhere, we really sat up and took notice. And I think that was one of the first times for me that there was a really clear perspective that global health issues are global issues, are truly issues of humanity. And what Ebola taught all of us is that we needed to look much more at how we live with animals. We needed to look much more at climate, and we needed to look much more at global public health and primary health.
Well, you have said that early pandemic science is filled with uncertainty. So what are your thoughts about the scientific and even the public and political response to COVID-19 so far? What have we done well and not so well?
Well, what we've done well, I think you just had a discussion about it. I am so pleased to see the vaccine science and how much it's progressed. It's incredible that investments that have been made in pandemic preparedness, investments that have been made in faster, more efficient vaccines have really paid off. And we have 3 vaccines in phase 3 trials in the US, which is pretty remarkable. We have a commitment, as you read, by those companies to have safe and effective products. So what I think has gone well is that. I think it's also been amazing to see the pace with which we've communicated with early publications, using things like Twitter and Facebook and other modern means of communication to share information. I think that's mostly been good. What I think we still haven't done well, if I had a top 2 on what I don't think we do well, one is I don't think we discuss uncertainty. It's okay to say we don't know yet. And yet, as caregivers, as scientists, as physicians, we always want to have an answer. Saying we don't know or it's not clear how something will work is better than getting ahead of ourselves. So we need to find ways to communicate uncertainty and find ways of updating when we do know more. I think that's essential. And the second thing that I have such regrets about is that the simple public health measures like social distancing and mask wearing have become political. It shouldn't matter how you vote to protect you and your family and others from a virus. And that for me tells me that we have to do a much better job of communicating how to protect our communities from infectious diseases where it doesn't become political.
Do you think that has to do with the fact that people perceive information to have been sort of confusing, frankly? You know, the CDC initially said that masks weren't required and so on. And because there's so much that was unknown, people perceived that to be mismessaging or perceived it to just be confusing.
I think you've hit the nail on the head. And again, if in fact CDC was trying to say, look, we have a shortage of masks and we want them to go to healthcare providers, we'll update you when we think masks can be used by the public. That would have been helpful. So I think that's what I mean by saying if we don't know, or we have a message we're maybe even uncomfortable with, but we need to share. I've always been amazed as an oncologist and as somebody who's interacted with so many very sick patients. Patients are so capable. Humans are so capable of interacting with you in a thoughtful way if you're straight with them. And so I think we do need to be straight with people, including when we either have bad news or when we have to update news where things have changed. Dr. Stoffels mentioned things like convalescent serum. If in fact there's some controversy or some concern about the pros and cons and there's uncertainty, let's talk about the uncertainty, because people need to have confidence in their leadership, especially leadership at FDA and CDC.
We have a question from Pamela from LinkedIn who asks, how do we see this coming to an end? Is there a critical mass of people who would need to get a vaccine before we can get back to full normal?
Well, let me say two things. One is I'm not 100% sure what full normal is going to look like. I think it's reasonable, even with a vaccine and even with the passage of time, it could be that coronavirus, like we have a common cold, like we have flus, that there's a virus that persists. I don't know that yet. I hope the vaccines will be widely used and highly safe and effective, but I predict that there are some behaviors that we will just change. I'm not sure we'll shake hands in the future. I'm not sure how we will live together, and that will be and needs to be science driven based on how much of the virus is around and how effective our vaccines are in eradicating it.
At the Gate, when you were at the Gates Foundation, one of the objectives was to really address concerns of people in marginalized communities. And we know that there are serious health disparities and inequalities and inequities all over the globe. So how do we best prepare these communities to be able to battle this disease before and after a successful vaccine becomes available?
This didn't change with the pandemic, but the pandemic really demonstrates the most vulnerable in our society. One of the biggest challenges we have is access to healthcare, access to preventive healthcare, access to healthy lifestyle, access to food. So the need to have equity in healthcare in the U.S. has absolutely been front and center. Gates Foundation focuses ex-U.S. And you've seen societies that do have much more equitable healthcare systems successfully combat COVID. It's a positive. But if you're thinking in your mind, can I afford that visit? Can I afford that testing? One of the things an epidemic really points out is that healthcare only if you can afford it isn't very effective healthcare.
So it seems that we weren't prepared at all for COVID in this country, at least. And that's had a huge impact on the way it has spread in this country. So what does pandemic preparedness entail? And what should we take away from this? And are more pandemics inevitable?
I think more pandemics are inevitable. I hope they will not be of the scope of COVID-19. Let's all hope that. I would give you two things that I think are top of mind for me in pandemic preparedness. One is the federal response. The CDC, the NIH, the FDA, the federal response and central leadership on pandemics and pandemic preparedness is essential. And that has to be rebuilt. It's extremely important. When in 2014, when we looked at Ebola, one of the critical success factors was being able to engage the US federal government, including the military. We have assets that almost no one else has. So one, first and foremost, a central, proactive federal response. The second thing is local. Each of our communities needs to have an effective public health department, something that keeps our communities, keeps the nursing homes safe, keeps the schools safe. We need effective community public health.
Isn't it astounding that the U.S., the leader of the free world, was so sort of, unprepared and inept when it came to, preparedness? It was just something that we just didn't seem to take seriously.
Yeah, it's shocking, and my hope is that as citizens, we demand that we make investments that will keep us safe in the future. We live in a democracy. We're all voters. And if citizens want different, we should push for different.
Yeah, that proactive approach is so essential in this process. The whole coronavirus landscape is just filled with so much controversy and fake news and conspiracy theories. How has the Gates Foundation handled that in the past when you were the head of it? And what advice do you have for people to be able to separate fact from fiction?
Well, one of the things that I learned when we started looking at the anti-vax movement is here's what doesn't work: shaming. Every parent loves their child. Everyone wants their family to be healthy. They may just come at it from different ways. And so what we learned and what I learned over and over again at Gates Foundation may seem obvious, but it's extremely important if you're eradicating polio, if you're getting rid of Ebola, if you want to do away with COVID-19. Who in a community is trusted? Is it the people in your local church? Is it people in the school? Is it a trusted long-term mayor? Working with local people and communities who are trusted and making sure that people can interact with folks that are just like them so that they can connect and relate to the people giving them information is an essential piece of community health, is an essential piece of interacting. In San Francisco, University of California, San Francisco did a lot of COVID testing in the Latinx community with folks who really needed to see trusted neighbors and trusted community members who could help them see their status. And they went to great lengths to make sure that that was community friendly. We need to do that all across the nation to say, look, it isn't some person in a white coat who I can't relate to. It's someone who I trust, who knows me and my family, who understands me and my challenges. The more we do that, the less we'll have fake news and the kind of things that are really in front of us as we try and combat COVID.
Those are certainly great suggestions, Dr. Desmond Hellman. I have a question from Brian from LinkedIn who asks, what actions are the scientific community taking specifically to combat false information?
Oh, there's so much dialogue. There's so much angst in the scientific community. I would say that some of the most productive actions that I see, and I encourage people all the time to do this, get out there yourself. Don't be in your ivory tower. So go give go to the Rotary Club, or now I guess the virtual Rotary Club, be a member of your community, talk to your neighbors, be out and about. And the other thing is, it's so very important, the educational system. Make sure that from a science education that we have more diversity and inclusion, because that will, again, connect to the community, and that students have a much better sense in their curriculum of how to interact with the community, not just their patients, not just with a stethoscope, but how to communicate on science education.
Such great information. Dr. Sue Desmond Hellman, thank you so much for joining us today. Hope to talk to you more in the future.
Thanks for having me.
It's great to see all of your questions and comments in the feed, so please keep them coming. Now, as we all know, it is that time of year, back to school time. My eldest just started school today. I'm sad I'm not with her at the moment, but that's okay. I'm sure she's doing fine. Now, as a mother, I'm personally dealing with distance learning and wondering when it will be safe to send my kids to school. So with so much controversy and confusion swirling about kids and COVID, I thought it would be beneficial to bring on an expert to talk about some of the issues on parents' minds. Welcome, Dr. Jackie Phillips, pediatrician and senior director in the Office of the Chief Medical Officer at J&J. She has spent her career adapting technologies to improve patient care and sits on the Executive Council of the American Academy of Pediatrics. Dr. Phillips, welcome to the show. Thank you so much for being with us. Now, there's a lot of conflicting information about how children are impacted by the virus and how they can even spread it. So what are some ways for parents to sort through the sometimes conflicting information and really understand the risks? Like, is there or are there definitive sources of information or evidence that you think every parent should be aware of?
Thank you. That's a great. At this time, there have not been any studies that measure how contagious children when they contract SARS-CoV-2. There was a recent study that demonstrated that young children without serious symptoms carried high levels of genetic pieces of the virus, the viral RNA, but not live viruses in their noses. It is unknown, though, how that leads to transmission. So the answer is we don't know right now. Your pediatrician is probably your best resource, as we do receive daily updates as to the science and what's out there. The number one thing that every parent should know, I think, is that wearing masks is effective in controlling the spread of the virus. That actually has been studied at a hospital in Boston, Massachusetts. One thing parents could do is start practicing hygiene at home with your children in an age-appropriate way as you prepare for in-person classes. Again, this has been said before by both guests, but community COVID-19 levels and transmission rates will determine the risk at the school. So the sooner we get, or people get, a community control their infection, the safer schools will be for children in the community.
So, Dr. Phillips, for parents deciding whether to send their kids back to school, what are some factors to consider? You know, how do we encourage parents to make decisions that protect teachers and staff? And how would you say financial privilege and socioeconomic status factor into the decision-making process?
Again, great question. So I'll take the last piece first. There's an established wealth education cycle. Wealthier families have access to better educational systems. The better educated you are, the more wealth you generate, and the cycle continues. So you would expect that lower income families would be disadvantaged in any number of ways, but certainly with remote learning. The digital divide has been well described. It's estimated that 1 out of 5 children do not have reliable internet access or even a computer in some instances. That's 20%. That's a large percentage. You add the loss of employment recently, pre-existing housing and creating housing insecurity, food insecurity, and low-income children could easily fall further behind. It is estimated before COVID that there was a 2-year gap between those communities to begin with. There's one study modeling that suggested that the shutdown in the spring added perhaps between 9 months and another year to that. So vulnerable children in those communities are certainly at risk. Parental decision, do I send my child back to school? This is a really difficult question to answer. The American Academy of Pediatrics did publish last week with their healthychildren.org group a couple of points to consider as you're going back to school. So some generally published guidelines adapted from the CDC and others. Some of them are common sense, but it's worth getting into having that discussion with your school district and your local school specifically, cleaning and disinfecting high-touch surfaces, washing your hands. And again, that's something parents could do with children at home and make that a part of their everyday lives. Distancing desks, having fewer students and staff in the classroom, moving the teachers, particularly in the lower schools, rather than the students. Having lunch at your desk, again, simple things. Using outdoor spaces whenever possible. And again, wearing masks for all teachers and children and adults. And finally, having the flexibility to change to virtual if the virus surges. So those are some of the things you have to consider.
We have a question from Maxine from LinkedIn who asks, will emergency use authorization include children? Will any phase 3 studies include pediatric populations to ensure safety and efficacy?
I am not aware of children being included in any phase 3 trials at this time. I would not anticipate that emergency use authorization would include children at this time. You may be aware of a prioritization that was released a week or so ago about who should even get the vaccine first and in what order from an ethical perspective. And it starts with healthcare workers. And again, they didn't quite define what a healthcare worker is. So it would be anticipated in the early stages that the majority of vaccines may go there. Essential services and all of that. And children were at the very end. So I would not expect that to be a priority at this time.
We are so many months into this crisis now, and if kids continue to do remote learning, what kind of impact do you think it will have on their mental health? And while they're not able to socialize with other kids, how do you think that will affect kids, given the time that they've been out of school so far?
Very important point, and it's going to affect children at different ages differently. Just as this virus is novel, remote learning in school-aged kids, K through 12, is also novel. And hopefully there have been some learnings from the spring shutdown that can be brought into the fall. But it's new to everybody. I've read where some folks have taken certain measures to improve upon that. Smaller classes, so that all in one class, all the kids will be on one screen page to engage them. The stress and anxiety is a significant concern. Part of school, as everyone's aware, is the socialization and learning how to interact, deciding who you are, conflict resolution, all those things that are important to making a human being. I would advise parents, that's another takeaway I would give to parents, is be on the lookout for stress, anxiety. And in certain communities, these children may have been exposed to the loss of life in their extended families or immediate families. And that alone can add to a post-traumatic stress situation. Anxiety, maybe mom or dad had to come down with the disease and, cause some stress in the home.
Dr. Phillips, do you have any suggestions? Yeah, and do you have any suggestions for how parents can look for those signs and what those signs look like?
That's a good question. If your child is behaving differently in any way, I would certainly reach out to your pediatrician. But children, when they experience anxiety and stress, oftentimes they can present with somatic signs, stomach ache, not sleeping well, night terrors, but it could even be more subtle than that. Loss of interest in things that normally interested them. Temper tantrums, you'll have to decide at the age group whether there are more temper tantrums than before or after. But any subtle sign can be a sign of stress and distress in the pediatric age group. But look for the somatic signs: nausea, my stomach hurts. That's a common sign of distress and anxiety in children.
Dr. Phillips, this summer's protests have shined a light on racial inequality in the US, and many are hoping these actions will spark long-term systemic change. As a woman of color in medicine, what are your hopes for inclusion and better practices in the scientific establishment, and how can we ensure that the next generation of scientific innovators is more diverse?
Yeah, that's an area of great need. I agree. So everyone knows that diversity is the engine that drives innovation, right? And diversity inclusion should be cultivated at multiple levels. A couple of things to start with is looking at the barriers to diversity inclusion. They should be defined, called out, recognized, and ultimately overcome. Two barriers that just come to the top of my mind are education, let's say. Early childhood education opportunities for every single person is a great step in leveling the playing field for all communities. STEM, science, technology, engineering, and math education in particular, needs a focus very early on. By the time you get to high school, it might be too late, okay? The second thing, which really needs a discussion ongoing, and I hope this continues in every facet of our lives, is bias, the role that bias plays, conscious and unconscious. This bias significantly adversely impacts diversity and inclusion. Workplace and career advancement opportunities, how they impact women, ethnic minorities, and socially disadvantaged populations is an important aspect. I actually think there should be an opportunity for voices to discuss with each other different ethnic groups what bias means to you, how do you feel in all aspects of this, not just what's been on TV and protesting. Healthcare, employment bias, housing bias, lending, pollution that disproportionately affects those communities. But education and bias, defining it, understanding it, creating a space where it can be discussed, defined, and understood, I think is a great place to start.
Yeah, it's so challenging because all those things you mentioned, they are going to be exacerbated because kids are now having to learn remotely, and there's so many disparities in how kids are able to learn and even being able to acquire the technology necessary.
I agree. It's a daunting barrier to overcome, but I think the time is right for serious attempts to be made at overcoming this. I noted with interest the previous guest's comments about investing in community-based health advocacy, for instance. Could that be a benefit in this area? Is there a role for public-private partnerships in this regard to sort of overcome all of these? And again, listening to people who look like you, whom you trust, but that does require resources. Perhaps that is something that could be public and private coming together to work on those issues.
Well, if there's ever going to be an opportune time, this certainly is it. Dr. Jackie Phillips, thank you so much for your time. We appreciate it.
My pleasure.
I want to thank all of our guests for being on the show today. Right now, we are all still searching for answers, and it's my hope that we can continue to provide honest, accurate information and open discussion about the COVID-19 crisis. If you have any guests you'd like to see on the show or have any lingering questions you'd like to have answered, please put them in the comment section. Now, we've talked about issues facing students and teachers right now. One group we don't necessarily think about is medical students. What's it like training for a future in medicine right now? Here are a few poignant testimonials from the next generation of healthcare heroes.
I definitely think that the pandemic has exacerbated burnout for healthcare providers. The ever-changing protocols, the limited information, and the underlying fear of getting sick or transmitting the disease to family and friends definitely takes its toll on mental health.
It added another layer of this emotional mental fatigue. And I think wellness initiatives and mental health initiatives are well-intentioned, but they feel kind of like Band-Aids sometimes, and not getting at the bigger issue of processing all the death and trauma and stress that healthcare workers experience day in and day out on their incredibly long shifts, incredibly long on-call hours.
I am so grateful for the people who have donated food and personal protective equipment and their time to supporting frontline workers. On the other hand, I don't want the expectation to be self-sacrifice within healthcare. We have to work on minimizing risk for our providers.
When we look at other heroes like firefighters, troops, we'd never ask a firefighter to go into a burning building to save people without proper equipment. And yet that's exactly what healthcare workers are doing. Going in with a shortage of PPE, having to reuse equipment that's meant for single-time use. So I think there's a big disconnect between the word hero and the actions that we are taking to protect these heroes.
My hope is that we collectively find ways to keep our communities safe. I think COVID-19 has really demonstrated to us how much we depend on each other and how interconnected we all are.
I hope this pandemic and our lack of preparedness for it and everything that we've learned from it serves as a shock to the system and allows us to value public health and disaster preparedness and scientific fact in a new way, both within our community and at the national and state level.